protozoa. The first one is the flagellate group. I'm starting already. And I'm going to working very fast today because we have another lecturer follow me, and he said, do not late. The first one is a uroflagellate. The second one is intestinal flagellates. And the third group of flagellates are blood and tissue flagellates. I'm going to start with the easiest one, the intestinal flagellate. I think that your handout still use the name duodenalist. Please correct it right into the intestinalist. So the old name is Lamblia. So when you heard somebody say this word, so that's all right. It's the same parasite, the same protozoa. But right now, on the new textbook, they use intestinalist for Giardia. And the other one is Identamoeba. These three, they are non-pathogenic, but they live separate in oral cavity. So just know the name. The Trichomonas tenax, Trichomonas hominis, and Chylomastix mesili. You're gonna see this, but you know that this is they are non-pathogenic flagellates in the human body. So we will focus on pathogenic, only the Giardia. Please pronounce Giardia, don't use G at all. It's not Giardia or whatever, it's Giardia. Giardia. So when you speak very fast, it's going to be Giardia. And Dientamoeba flagellates. For uroflagellates, we're going to cover only one. It's Trichomonas vaginalis. This is the sexual transmitted disease caused by Trichomonas vaginalis. When you hear or look at the name, you know where it is already, because it's the habitat in the vagina. So we call it Trichomonas vaginalis. Very easy and simple. And the third one is blood and tissue flagellates. We have two genus, Leishmania and Trypanosoma. We don't have Trypanosoma in our country, but so far we don't know because the world is so small. In the previous time, we don't have Leishmania at all, but right now, we're gonna see more cases of Leishmania. And this group required vectors. So you understand the meaning of the biological vector. It means that life cycle needs insects or vector to complete the life cycle. For Giardia, this is the habitat. So you learn from amoeba, the Entamoeba histolytica, where is the habitat? Where is the habitat? You know, I know intestine. Where is the habitat, small or large? Large. So right now, another one, they locate in the small intestine, mostly at the duodenum and jejunum. So remember where they are, so you know signs and symptoms. I always say that, understand the life cycle well, so you know how they produce symptoms in patients. And if we can find this protozoa in the common bile duct or gallbladder or pancreatic duct. Once they are in a heavy infections, they can spread from the habitat to other habitat too, but it's not common. It's not very common. The common place is the duodenum and jejunum. And of course, the high risk are children, because of the habit of the children that can get the infection very easily. And of course, this is a traveler's diarrhea. When this name, it means that foreigners who go abroad or go to other countries, they have to be warning from the public health officers about this infection. Be careful of getting infection in other countries when you travel. One of it is Giardia, because it is very easy to get an infection by drinking water on the street because they can survive in water, in drinking water. So this is one of the travelers' diarrhea. And of course, it is getting the infection from the homosexual. And this is a very old survey, but I can say still, right now, we still have this kind of prevalence. Even you look at the year, it's very old. But right now, I can say that the prevalence is around here for the children, 5 to 8%, depends on where the school is. If the local school in Bangkok, it might be lower, but schools on a urban or suburban, it's going to be around this number, 5 to 8%. But right now in the orphans, it's less and less because that we take a stool exam every year and we give them anti-parasitic drugs. So the prevalence is lower and lower. It's getting better in the orphanage in Thailand. And very simple right now, I'm going to tell you, forget everything about egg, larva, and adult. From now on, we don't want to see any writing down of eggs because this is only cyst and trophozoite. So very simple life cycle. This is the infective stage, the cyst, and get into the intestine and get the excitation and multiply using the trophozoite. And then when they want to get out, they have to form the cyst, and then they can get out into human feces and get into the environment. And once again, getting back into the host by ingestion. So mode of infection is ingestion, right? And how about the mode of transmission? Everywhere, because this is the cyst can contaminate in water, in food, and this is the infective stage, which pass in the stool. So fecal oral infection transmission can be occur, right? Because this is the infective stage in the stool. So once you understand it, you know how they can spread. I'm not going into detail, so I let you look at the morphology tomorrow morning, how they look like for the trophozoites. But remember one thing, this is flagellate. So for trophozoite, you can see flagellates in the trophozoite. And once it is trophozoite, they can move. So we're going to have samples for you tomorrow. You take a look for the movement of Giardia in saline or in simple wet smear. And I just want to show you only this morphology that they have to ventral sucking. This is here. So they can use this area to attach on the small intestine, only attached. They cannot invade. They attach and they use this part to attach. And the motility, you look tomorrow. They say the falling leaf movement. Take a look. It's look like falling leaf or not, but for me, it's not like falling leaf at all. Take a look tomorrow. This is a textbook description. So just from the textbook, but look by yourself tomorrow how they move. And the cyst, some of you look at the cyst today. It's very easy and simple for the cyst of Giardia. And I'm going to tell you that everybody in this room, you must, I say must, know how to identify Giardia, because it's not only in the third year medical cadet year. You're going to have this in the ward, in the NL2 exam, not only NL1, NL2, NL3. So it's the spot test all year round, because this is very common protozoa infection in children. Not only in children, but in some adults can get the infection too. Very simple and easy, oval shape. It is oval, it's not round. So it's very simple because I think it's not very much that have an oval shape for protozoa. And if you take a look here, the exostyle, you can see the remnant or the trace of the axostyle here. And when we call the retracted cytoplasm, it means that, take a look here. You can see the space here, so you can see the retracted. It means that the trophozoite retract themselves. It means that หดตัว so you can see the area, small area is a hollow area in the cyst. Very easy and simple. And symptoms again for protozoa, you know that not only 100% causes symptom, it's only 20% cause symptoms. Most of them are carriers. And ingestion the cyst. So infective stage is 4 nuclei cyst here, and excitation occur in the stomach. And they need bile to stimulate their growth. So you know that they require bile. So the habitat should be around small intestine, right? Multiplication occur in the duodenum. And once they're going to leave the body, they need the excitation, and still they require the bile salt to stimulate the encystation before they came out of the body. Okay, a keyword from the case, you should look at the keyword. 5 years old, diarrhea and stunt, intermittent diarrhea for 2 months. It means that she has chronic diarrhea, right? And it's not contain blood and mucus. It means that it's not invasive. It's acute watery diarrhea, and she lost 5 kilograms. And this is very common that usually occur for small children. This is a stool exam. And once you see this, you know how to manage the patient, right? Give the treatment, give the suggestion how to avoid the injection, the infection. And this is very common. I'm going to ask something. Again, I put it down. Falling leaf appearance. For this girl, is it all right? Is it common to see both cyst and trophozoite? It is common? Answer, please. She has watery diarrhea for 2 months. Can we detect trophozoite in the stool exam? Because of the cyst required for the transmission, right? But for this girl, she has diarrhea and watery diarrhea. Can we detect trophozoite in stool exam? Use your common sense. Once she has diarrhea, so it's no time for the body or for the protozoa to do the encystation or have the cyst wall, right? So she can pass both trophozoite and cyst, but most should be trophozoites because she has diarrhea, watery diarrhea. So trophozoite can be detected in this case, all right? But for in general, that have the loose stool or common or normal stool, we always detect what stage? Cyst, yes. For normal stool or loose stool, we can detect cyst. But for this girl, it's common to detect trophozoite. In this case, mostly trophozoite more than cyst. All right, she got the infection by consuming water. So waterborne transmission is the main, from drinking water or from foodborne by eating raw vegetable, or fecal oral transmission if she plays with her friends or in the orphanage, in the orphans. So this is common, but this is the most common. So I put the 2 stars here, waterborne transmission. And of course, for person-to-person transmission, the daycare center, small children play together. So it's very common to get the infection by their friends in daycare center. And don't forget about zoonotic transmission, because Giardia has other species too, not only intestinalist, but it's not very common. We found that in the people who handling with the infected animals. So look at here. The cyst wall can resist the disinfectant or the chlorine in water. So The cyst can survive in chlorinated water. Don't forget this one. This is a very typical, and you should remember. The cyst cannot do no harm to the body at all. This requires for transmission. Only the trophozoite can feed, can multiply, and can replicate. So these trophozoites multiply in body and cause signs and symptoms, not this one. This one will cause only for the transmission in the life cycle. So the pathogenesis, I'm going to talk very fast for you because you can take a look in the handout, because I have read it and it's very clear that they use 3 steps to cause the pathogenesis by the trophozoites themselves. I said to you already about the attachment of the parasite on the villi. So this is a physical blockage. And the second thing is a direct damage by the parasite, and they need food. We eat food too. So the competition of the nutrients from the protozoa and the host. And take a look at this is the villi, and this is the electron microscope. So they use the sucking disc and cover on top of the villi. So they cover, and they use the lectin from the parasite, and this is the lectin mediate mechanism to cause the physical blockage. And take a look at the villi. So this is the small parasites cover here and here and here. So this is they produce thioproteinase to damage the intestinal epithelium. And they compete the nutrients from the host. So they require bisol, trypsin, chymotrypsin, and lipase. So what happened to the pathology caused by the trophozoite? I mean only trophozoites. No cyst. Cyst can do no harm to the villi, only trophozoites. The trophozoites cause shortening of the villi, elongate of the crypt because of the hyperplasia of the crypt, and blunting of the microvilli. And look at the EM from these pictures. You can tell from the normal villi, and this is caused by Giardia infection. So they cause the mucosal dysfunction, shorten villi, and cause malabsorption. And of course, take a look at the picture, you can imagine diarrhea can occur. And for the exam, stool exam, so of course, remember the case, that girl, we do the stool examination. It's a very simple and easy method to diagnose Giardia infection. I think last year, we have a case of not a small girl, growing girl already more than 10 years old. She had diarrhea for more than 6 months, and their parents worry so much because that she cannot eat and bad sleep at night, and stool exam was negative. So think about that. Once stool exam was negative, so more diagnosis gonna be more and more and more to prove what is the happen with the diarrhea with that girl. So at last, the stool sample was sent to our department, and I don't understand what happened. That's why the lab missed diagnosis with the stool exam. So once we take a look under the microscope, a lot of cysts and some trophozoites we can see from her stool. So it's very simple and easy. So after taking the drug for 3 days, everything's gone. I mean, all signs and symptoms that happened for 6 months, gone. So it's like magic. So stool exam for the cyst or trophozoite, and this is very good that if negative, repeat stool exam. Repeat once or twice for the stool exam. So it's gonna be clear for you once the lab sent you and they said negative. So do it again for 3 times. So you want to make sure. And this is the picture of the cyst, and this is the stain of the trophozoite. Simple and easy. metronidazole or tinidazole, and this is single dose. Very simple and easy. Choose your drug, the convenient drug that you have at that time, metronidazole or tinidazole. So for symptomology, I'm talking about that most of them are asymptomatic. And 2 and 3 is acute and chronic infection. For chronic infection, it's only 30 to 50%. And for Giardia, chronic infection causes chronic diarrhea. The same as that girl, intermittent diarrhea for 2 months is a chronic diarrhea and cause the mucosal dysfunction. So we're going to see about the case about 50% steatorrhea. The decreased absorption of fat. So it means that you have the greasy stool. When you take a look by your naked eyes, you see some oil or fat in the stool. So it's like greasy stool. You understand the word greasy? Man, wow, wow. By your naked eyes. And some cause the anemia because of the decreased absorption of folate. And for chronic infection, this causes the malabsorption syndrome and decrease of the carbohydrate, lactase, vitamin A, and vitamin B12. And take a look, remember for that girl, she had marked weight loss and malnutrition because of the girl reduced the growth compared to the normal, in the same age. Growth retardation children. So this is the picture of chronic infection. So if you remember the case, you know how chronic infection look like. All right. For acute watery diarrhea, flatulence, and this is a very non-specific symptoms, right? This is a non-specific GI symptom for acute diarrhea. See, flatulence, anorexia, and nausea. So it's not very specific. It's very common for the GI symptoms of something or inflammation of the intestine. And most of them is, for normal, the cyst can be eradicated by our immune mechanism. Which one? Helper 1 or helper 2? What? Helper 1 or helper 2? This is extra intestinal protozoa. Helper 2. It's helper 2. It can be eliminated by immune mechanism. So eradication of the infection occur in general, but some can persist and have the symptoms. This is not, I think it's common, but it's not very common to diagnose this parasite. It's not very easy. If you take a look at the name, it's a diamine 2, right? So imagine about the morphology of the parasite or the protozoa. You take a look at 2 nuclei because we call it diendamoeba. So 2 nuclei. And the name of the genus is a Flagellate species. Flagellate came from fragile. What does fragile mean? Fragile or fragile, it means แตกง่าย So it's very simple. Once the protozoa excrete in the feces, it can fragile or break down. So it's not very easy to detect in the stool exam in general. Most of them can be detected using stain, the permanent stain. So in general, the lab will not work on the stain specimen. So the habitat again is large intestine. The thing is that this is very common using pseudopodia, and why we include it as the flagellate, because the morphology looks like amoeba. But in detail, when they take a look under the electron microscope, we saw a parabasal body. This is the organelle of the flagellate. So they changed from the protozoa to flagellate because of these organelle they found in the electron microscope. And the size is very small, 5 to 12 microns. So This is binucleated, no flagellate, but we call it flagellate because of the parabasal body, and the pathogenesis is unknown. So I just mentioned this to let you know that this is a pathogenic protozoa, but it's very rarely, that report in the lab because of the fragile or very easy of broken down by themselves in the stool after they came out from the body. I'm going to go very fast. And this, another non-pathogenic flagellate is the same as Entoinana iodamibal bushlii, that if it is, they are non-pathogenic, but you may take a look in the stool exam and you should know it. So chylomastic mesnili, and this is very simple and easy because that we have three kinds of trichomonas. The first one I mentioned a little bit earlier, Trichomonas vaginalis, is in vagina. So it's this one, this is large intestine, and this is a hominis. So once you see something moving using flagella in stool exam, so this is the one. It's very simple because they live in the large intestine. And another one is the T-nex. It's in the oral. So once you remove something else from the teeth, from here, take a look under the microscope. You see something moving, like a flagellate moving. It is a Trichomonas T-nex. It's an oral hygiene. It's not very good. So you see Trichomonas T-nex, the flagellate moving in the oral cavity. So they live in the different habitats. So once you see something moving, flagellate moving, you know what they are by looking at the flagella movement. This one, since it is non-pathogenic, I'm not going to go into the detail, but take a look at the morphology. Very simple and easy. This is like lemon. When you see the lemon shape here, so you know this is a chylomastic mesnili. It is non-pathogenic. And this is, I mentioned earlier, hominis. This is non-pathogenic, and it lives in the, where? In the large intestine, and jerky movement again. So you know that this is non-pathogenic, flagellate in the large intestine. One thing that I want to emphasize here, that the group of Trichomonas has no cyst in the life cycle, no cyst. They have only the trophozoite. So trophozoite is the infective stage. Trophozoite is the causing the signs and symptoms, but this is non-pathogenic. So Trichomonas has no cyst in the life cycle. So it's only one stage in the life cycle, only the trophozoite. And the last one for the sexual transmitted disease caused by Trichomonas vaginalis. And again, this one, when you see this trophozoite, the movement can tell from the jerky movement and no cyst. We're gonna see it tomorrow by the simple smear because we're gonna have a fresh preparation of the Trichomonas tomorrow. So you can take a look for the jerky movement of the trophozoite of Trichomonas vaginalis. And of course, this is the STD, so the infection acquired by sexual transmission or sexual intercourse. And diagnosis, very simple. Once it is in the vagina or in the urethral, so you take a look for the trophozoite, take a look for the movement of the trophozoite. You see jerky movement and you see the flagellate amoeba, flagellate protozoa. You know this is a Trichomonas vaginalis. And this is a flagella, the stain, Trichomonas vaginalis. You see from the fresh preparation, you see jerky movement. A 30-year-old girl, no, not girl, woman, female, abnormal vaginal discharge and vaginal irritation. So the keyword are here. Take a look at and she reviewed the greenish vaginal discharge. So the discharge is in greenish yellow color, and with a follow is a bad smell. It's not a good smell, it's bad smell. And erythematous, swollen, red and swollen, it's erythematous. And there's a small punctate hemorrhagic spots on her cervix. So this is the description of what we see from the vagina. And take a look at small spot here, the erythematous. So it's information of the vagina. And the greenish, not greenish, this is a discharge, vaginal discharge. So once you take a look at this, is a strawberry cervix. They describe from the picture they see. So they describe it as a strawberry cervix of the vagina because of the inflammation caused by the parasite. Take a look and closer. No cyst in the life cycle, no cyst. Trichomonas has no cyst. So transmission caused by sexual intercourse, and only one form in the life cycle. So the multiplication occurs in the host, and once it's outside the host, they die. They cannot survive outside the host. So this is only very simple life cycle from one host to another host by sexual intercourse. And that's a very simple life cycle of a Trichomonas vaginalis. For the male, most of them, this is anatomy of the male. So for the female, anatomy of the female is very good for Trichomonas vaginalis. They prefer the squamous cell of the vagina or the ectocervix of the vagina. So it means that anatomy of female help the signs and symptoms occur in female more than in male. And the pathogenesis caused by the trophozoite is 1, 2, and 3. The first one is a cell-to-cell adhesion. And the second one is a hemolysis. And the third one, they secrete the enzymes from the parasite to destroy the squamous cells. They produce adhesin. This is a thing that produced by the parasite and use the receptor. The host receptor is the squamous cells. So they use this one to cause the cell-to-cell attachment between the parasite and the host cell. And the other binding protein, which is not, this is produced by the parasite, but it's the most important thing is the adhesin from the parasite that causes the cell-to-cell adhesion. And of course, they have to use the Weber cell because they don't have the source to produce the fatty acid and cholesterol. They cannot synthesize this. So the precursor they require from Weber cell. So they need to lyse the Weber cell using the virulence factor. So this required Weber cell in the life cycle. So the first thing is cell-to-cell attachment. The second thing is that they require Weber cell from the host. They have to lyse the Weber cell and need it as the precursor to synthesize fatty acid and cholesterol. And the third one is that they secrete the cysteine proteinase. It's an important enzyme to destroy the squamous cells. So the squamous cell, once they attach together like this, once they produce the cysteine proteinase, the cells detach. It's a cell close together, right? Once they produce the enzyme, the cell detach. Cell กว้างออก detach. And they have the cell detachment factor. It means that they cause the cell to losing from each other. And this work at pH 6.5. Very good at 6.5. But during the menstruation period, we have the beta estradiol decrease. And once the estradiol decrease during the menstruation period, the CDF factor increase. So this occur during the menstruation. This a reason when they explain why symptoms are more. The symptoms are more during the menstruation period of the women because the beta estradiol decrease at that time. So once the beta estradiol decrease, the CDF or cell detaching factor increase. I mean the function more and more during the menstruation period. I talk about the target cell, the squamous cell of the vagina. So this is the target. So what happened? Of course, it's an acute non-specific inflammation of the mucosa and submucosa that's describe that woman that have the erythematas and edematas. Once talk about that, why we can see the erythematas in that female. So this is a non-specific inflammation occur in the mucosa and submucosa. And once they produce the protease and this one, so this causes the contact-dependent cytotoxicity. Cytotoxicity, it means that they can destroy the cell. And the pathology in the female, the edema and inflammation of the epithelium. So the cell has a degeneration and desquamation. It means that once it's caused the degeneration, cell degenerate, and desquamation, it means log off. You can imagine the cells was destroyed. Cells are destroyed and then move out. And we see the petechial hemorrhage. We see spots, inflammation and spot of the hemorrhage. So the picture, they describe the strawberry cervix from the picture they saw. I'm going to move back to the picture again. They describe everything as strawberry cervix from the naked eye here because of the petechial hemorrhage. Once it's caused the inflammation of the ectocervix or subcutaneous cell. This is the hemorrhage. For female and male, when we compare signs and symptoms, in male, mostly asymptomatic because of the anatomy. I mentioned earlier, because the anatomy of male and female. The anatomy of female has the very good condition and good place of squamous cell for trichomonas to multiply and attach to the epithelium very easy compared with male. So most of them are asymptomatic or asymptomatic here. But if present, it's very mild symptoms of urethritis, dysuria, and prostatitis. So very, very normal, minor for female, for male. Even they wouldn't complain much compared with female. But for female, most of them are symptomatic. And vaginal discomfort is a complaint, chief complaint. Itching and burning because inflammation occurs. So itching and burning sensation come from severe inflammation of female in the vagina. So this is a chief complaint, the same as that female came to see the doctor. And leukolia. It's a thick leucolia. What do you call it in Thai? Leucolia ตัวขาวค่ะ leucolia. Greenish yellow foamy. Remember the picture of foamy. Again, greenish yellow foamy. What you gonna say in Thai for foamy? เป็นฟอง Back again. Foamy. Strawberry cervix. All right. Greenish yellow discharge. Very simple. Just demonstrate the jerky movement of the parasite of the protozoa in vaginal discharge. So we know we're gonna see only the trophozoite. We cannot see the cyst because there's no cyst in the life cycle. Only the jerky movement of Trichomonas vaginalis in simple smear using the vaginal swab. You can see the parasite moving already using the flagella. And for urine, you use the sedimented urine and take a look. And for male, use the prostatic fluid, use the simple smear. So we don't use a very complicated examination. Use simple urine or vaginal discharge to take a look for the movement of the protozoa using flagellate. So the movement is jerky movement. What do you call jerky movement in Thai? Jerky กระตุก move เคลื่อนที่แบบกระตุกชัดมากเลยนะคะเวลาเห็นตัวอะไรบางอย่างที่เคลื่อนที่แล้วกระตุกได้กระตุกเมื่อใช้ flagella แล้วก็ undulating membrane มันมี undulating membrane มันเลยกระตุกเดี๋ยวขึ้นไปดูนะคะใน lab ถ้าตอนที่ดูเมื่อเช้าไม่เห็น For treatment sexual partners should be treated simultaneously. What does it mean? What does it mean? Treatment both female is positive, so give the drug to the male too. So it means that if the wife is positive with the trichomonas, give the drug to the husband too. Both partners, or if they have more than partners, give all of them. And the drug is very simple. You're going to use metronidazole, tinidazole, or nidazole, depends on your convenience, what you have in your hands. Anything, metronidazole, tinidazole, or nidazole. This one is not very common in Thailand.